Good evening, everyone. Today, the topic of presentation is approach to dizziness. So, this is a common complaint we see in the OPD and IPD basis where patients tell us the complaint of dizziness. They are like they tell room is spinning around, or that like fear of falling or something, where they're feeling like losing consciousness. This is a common complaint. Let's look into it in a case-based scenario. Before going into the case-based scenarios, we'll look into what is dizziness. So, dizziness is a common symptomatology by the patients, but it needs to be categorized based on the symptoms they are giving. So dizziness can be categorized into it's a vertigo. It can be categorized as vertigo, disequilibrium, and presyncope and lightheadedness. So all of these vertigo, disequilibrium, presyncope, and lightheadedness are interpreted as dizziness to the patient. But if you go into the symptomatology per se, you can actually categorize into based on different things. Vertigo is more like when the patient is like he will tell you the more like the room is spinning around me or things are spinning around me. It's like the spinning sensation is vertigo, and it is mostly like 40 to 50% of cases of dizziness are to the vertigo. And what is disequilibrium is I'll give an example like in a case of any Parkinson's patient or any peripheral neuropathy patient, they feel they're unable to, they feel they're about to fall or something, like they're losing balance or something, because in peripheral neuropathy they are not able to perceive the sensation of ground. So they feel that they're off balance and they're about to fall. And this attributes to 15% of cases of dizziness. So this disequilibrium also be kept in mind. And how pre-syncope work is, they're about to lose conscious, like they're blacking out or something. It's like feeling of lose conscious, like it's more like they're about to black out or something. This attributes to 15% of cases. And lightheadedness is if you ever see a patient of panic attack patient, they are very tachypneic, hyperventilating. They don't know, they're completely disconnected with the external environment. They don't know what's going on around them. They're completely confused. They're very hyperventilating, tachycardic, very anxious. They're commonly seen in the people who are very anxious and high history of panic attacks. They're lightheaded, like the little lightheaded. They're especially feel that sensation when they're in the closed spaces or in the lifts when they're trying the crowded places or something. And it's attributed about 10%. So before labeling a dizziness, this is a common symptomatology. You need to categorize based on the symptoms they're telling. If there's a spinning sensation of things and room around, that is a vertigo. When the patient is feeling that he's about to lose balance, that is disequilibrium. And the patient is feeling he's about to have a blackout or something, that is more of presyncope. And the patient is feeling lightheaded, that is about to like he was about to die and he was about to losing continuous, completely disconnect from the environment. He's having hyperventilating tachycardia. That is more of lightheadedness. So before going into the discussion, I want to tell you one important test which is called hints examination, which we generally don't do nothing. We actually do this, and to differentiate between peripheral and central vertigo. We are coming into the discussion of vertigo first. So these three tests will tell you whether it is a central vertigo or a peripheral vertigo. So what is this test? Actually, there are very few clinical tests which are more sensitive and specific than a radiological or biochemical report. So what is, I'll give you a case scenario before telling this what is this hints examination. A 55-year-old female presented to the emergency with the complaint of dizziness and blurring of vision. She said she had previously complaints of multiple vomitings all day, and she was actually checked, and we got a CT done. CT was normal. They thought it was probably dehydration related and sent her home. And then later, one day later, she actually presented emergency with complaint of dysphagia, diplopia, and a motor deficit and vertigo and all. So she landed up in a full-blown stroke. So here the CT was normal. The CT, we know CT was not sensitive enough to detect the ischemic stroke earlierly. Maybe we thought maybe we should have got DWMRI done. So, but this is one test where the hints examination test is one test which is more specific and sensitive than DWMRI itself to differentiate between central and peripheral causes of vertigo. So any emergency patient that is presenting with vertigo, any your IP patient, you do this test, which is very simple. It takes hardly 5-10 minutes to do this test to differentiate between peripheral and central vertigo. So we will go into this test. What is this test? First step is head impulse test. So before going to the head impulse test, I'll tell you what is head impulse test. Head impulse test generally tells about the intactness of vestibulo-ocular reflex. I'll give an example. What is vestibulo-ocular reflex? Let's say we are running in a forest. Like we are running in a forest, we are trying to chase something, we are trying to concentrate on something. We generally, though our head is moving around, our body is moving, we will be able to fixate on the object. We don't find it very hard to fixate on the object which we are following. This is due to the vestibulo-ocular reflex. When the head is moving around, is telling it sends a reflex to the brain to sense it. Its head is moving, so that you need to fix it. You need to adjust. That is vestibulo-ocular reflex. So this head impulse test is mainly to test whether the vestibulo-ocular reflex is intact or not. Generally, vestibulo-ocular reflex is lost in the peripheral causes because the vestibular nerve is affected. So that is in vestibular neuritis or labyrinthitis. So where vestibular, the peripheral causes vestibular nerve is affected, so there is no vestibulo-ocular reflex. So whatever fixation is needs to be done, it needs to be done by central pathway. So I'll tell you how. Let's say you hold the head and move the head around like 10 to 20 to 20 to 30 degrees or something. Generally, you ask the patient to fixate on your nose or something, vision, his eyes to fixate on it. Generally, in he doesn't the eyes doesn't move much because the vestibulo-ocular reflex is normal, intact, so the eyes doesn't you will be able to fixate on your eyes, the eyes doesn't move. In the case of peripheral vertigo, because the vestibulo-ocular reflex is affected in the, especially on the side of lesion, especially if the right side problem is present, the right side will be more affected. So generally what happens is when you move the head down, the eye moves towards that side and make a sudden corrective saccade, like it make a correction and come back to that to fixate on that whatever you're asking to look, like you're asking them to look at the nose, it will make a corrective saccade and come back. So this corrective saccade is done by central system. Because vestibular ocular reflex is not present, the information has to is processed by central pathway and has to fix it. So this corrective saccade is generally present when the vestibular ocular reflex is absent. So in normal people, since the vestibular ocular reflex is intact, generally there won't be any corrective saccade or something. There won't be any sudden jerky movement. You will be able to fixate normally. The eyes doesn't move much. If there is a peripheral problem when the vestibular ocular reflex is absent, it will make a corrective saccade to come back to make a comeback to that fixate on the eye problem. This is head impulse test. What is nystagmus? What do we do in nystagmus is generally you ask them to look at the finger and move that side and that side. What is important to differentiate in peripheral and central vertigo is whether nystagmus is unidirectional or multidirectional. So what is this in nystagmus? What happens is when you are asking to look at the like I'll give an example. When you ask the patient to look toward the right, general nystagmus is defined by the where the fast component is going towards to. So when you ask the patient towards the right, let's say the fast component towards the left. So this is called left-sided nystagmus. So when he is looking toward the right, there is left-sided nystagmus. When you ask them to look to the left, he will still have left-sided nystagmus. That is unidirectional nystagmus. No matter what your gaze is, where you are looking at, the direction of nystagmus is always same. That is unidirectional nystagmus. This is generally seen in peripheral problems. Maybe if he has a left-sided problem, let's say left-sided vestibular neuritis is present, maybe the left-sided nystagmus will increase on looking towards the left side, but the direction is same. The direction is always the same. Maybe if the left side vestibular neuritis, maybe if he is looking toward the left side, the left side nystagmus frequency will increase. When you are looking to the right side, still left side nystagmus is present, but it is not prominent. So the unidirectional nystagmus is most common in peripheral vertigo. In the central vertigo, what will happen is when you are looking towards the right, there is left-sided nystagmus. When you are looking to the left side, there is right-sided nystagmus. There is change in with the gaze. There is change in the nystagmus side also. So this is bidirectional. Like the direction keeps on changing with the way you are looking. This is directional change is seen in central vertigo. And in central vertigo, you see torsional nystagmus, vertical nystagmus are also seen in central vertigo. So this, in any direction, whatever gaze you are looking, there is only one-sided nystagmus that is more suggestive of peripheral vertigo. But with the change in the gaze, we are looking at the right side, it is more left. When you are looking at the left, the right side is more a central nystagmus. It is also a vertigo or torsional nystagmus can also be present. What is test of skew? So test of skew is very simple. You cover the eye and you uncover the eye. So when you uncover the eye, if there is any vertical movement that is coming back, like when you cover the eye, let's say eye is going to the vertical upward or downward, let a slight damp position. When you uncover the eye, it is again coming back to the normal position. This is called test of skew. That is skew deviation. Skew deviation is generally present in central vertigo. It is central vertigo. So skew deviation is that when you cover the eyes generally move towards vertically upwards or downwards, and when you uncover the eye, they again come back to normal. This vertical saccade is called central vertigo. This vertical saccade is called skew deviation. This is generally seen in central vertigo. So this generally if you cover and uncover the eyes in the normal position, there is no vertical movement of that is called no skew deviation. So these are the three tests that needs to be done in the any bedside to differentiate between peripheral and central causes of vertigo. So in central vertigo, there is no saccadic correction is there. Like generally vestibulo-ocular reflex is generally intact, no saccadic correction is required. In the case of peripheral causes where the vestibulo-ocular reflex is not present, it has to make a correction. It will make a sudden jerky movement, that is called head impulse test. When you move the head around, it has to make sudden correction to fixate on the back on the point. Nystagmus is generally unidirectional and horizontal in the case of peripheral, where in the case of central it changes with the gaze, more of by directional change is present, vertical torsional nystagmus is present. And skew, with when you cover and uncover the eye, the vertical movement is present, is called skew deviation. Skew deviation is generally present in central and absent in the peripheral. I will also share the video how do you do this test along with this presentation. You learn the test and do it in the bedside so that you will definitely central and peripheral causes of vertigo. So with this understanding, you will briefly discover what are the peripheral and ventral causes. Peripheral, benign paroxysmal positional vertigo, Meniere's disease, and Cogan syndrome, which is a vasculitis which presents the interstitial keratitis, tinnitus, hearing loss. That is a vasculitis, a variable vasculitis disease. And if any problem in the vestibular nerve, that can be vestibular neuritis or any acoustic neuroma, Ramsay-Hunt syndrome due to the infection of Apis jaw. So vestibular paroxysmia, it is also present as episodic vertigo due to the neurovascular compression. Like at cerebropontine angle, there is a neurovascular, there is compression of the vestibulocochlear nerve by the neural vascular bundle that can cause the episodic vertigo. Vestibular paroxysmia is that present. So all in the blue mark are the ones which cause episodic vertigo. And generally BPPV, all BPPV Meniere's disease are the common things which have episodic vertigo. And vestibular paroxysmia also can present as episodic vertigo. Central can be stroke, TIA, multiple sclerosis, any cerebral problems, any vestibular nuclear problems can all present as central vertigo. Central vertigo is little uncommon. So we'll go into the case-based scenarios. A 21-year-old woman presented with acute onset of vertigo and nausea. She had prior episodes of upper respiratory tract infection and no hearing loss is present. And physical examination revealed left-sided beating spontaneous nystagmus in the primary gaze. The nystagmus decreased in the right gaze and increased in the left gaze. Brain MRI was normal. So this is a 21-year-old female, and she had nausea and vomiting. And there is a history of respiratory tract infection. And physical examination revealed there is left-sided nystagmus which is more towards which is increased on left gaze. So there is only unidirectional nystagmus, but the frequency is more on the left gaze. Probably the left-sided problem is there. So there is no hearing loss. Why this hearing loss is important? Because so generally hearing loss is present in the case of labyrinthitis and Meniere's disease generally have hearing loss. Like BPPV and vestibular neuritis generally doesn't have a hearing loss. In the peripheral causes, more 4 common causes are present. One is BPPV, next is vestibular neuritis, labyrinthitis and Meniere's disease. Generally Meniere's disease and labyrinthitis have hearing loss. They have history of hearing loss. And whereas BPPV and vestibular neuritis generally doesn't have hearing loss. BPPV is more of Stone's problem, that is an equilibrium problem to maintain the head position and all. And vestibular neuritis is already the cochlear nerve is separated, so there is not much of hearing problem. So in labyrinthitis and in the Meniere's disease, you find a hearing problem. Here there is no hearing loss. So this is definitely not Meniere's disease or labyrinthitis. So here BPPV and the vestibular neuritis are the possibilities. Here they are telling the history of upper respiratory tract infection. And also the thing is BPPV generally present, it's a sudden onset. It's more of like episodic, like small episodes, episodic presentation, like when you're getting up from the bed, when you're getting up from the floor, you'll feel 30 seconds to 1 minute sensation of spinning around room around you. So that is called of BPPV, that is more of BPPV presentation. So here it is not like that. So this can be a case of vestibular neuritis. Mostly this is a case of vestibular neuritis because there is a prior history of upper respiratory which can be viral. So and also there is a unidirectional nystagmus towards left side of vestibular neuritis is a possibility. You can try antihistamines, antiemetics for symptomatic management. Along with that, you can try antivirals and steroids, which are controversial. You can try them and for a few weeks and see if there is any improvement. So the main management is symptomatic management, and also along with that, steroids and antivirals can be tried. And the general improvement occurs in weeks to months. Till then, the opposite tries to compensate. Say a football player, 33-year-old, who played in the defense position in the Indian Championship, and he had not suffered dizziness or vertigo prior to this episode. He has a medical history of cluster headache and migraine with visual aura, and history of childhood migraine and repeated bilateral ear infections. He observed dizziness while getting up from the bed and also from the floor. So this is a 33-year-old male who is playing football at defense position. Why is that significant? Is any player who is playing the defense position, he has to head the football a lot, so to defend the ball. So he is at significant risk of head trauma. That is one significant thing. His history of migraine, cluster headache, which is symptom free in the last 2 years. This is definitely not migrainous related vestibular migraine or something, because he does at present time he doesn't have any headache, photophobia, phonophobia, any migraine symptoms are not present. If they are present, we might have labeled them as a vestibular migraine, but he has history, but they are symptom free. It's not a migraine. So what is this? He is observing dizziness while getting up from the bed and from the floor. There is a classical history of BPPV. BPPV can occur due to the hundreds of causes. That can be due to infection, that can be idiopathic, that can be due to trauma. Some inflammatory causes also can cause BPPV. So though BPPV classically present when you're getting up from the bed or from the floor, sudden shift in the position will cause dislodgement of stones, and so they can cause the symptomatology of vertigo for few seconds to minutes. Generally peripheral vertigo generally lasts for few seconds to minutes, whereas central vertigo lasts for a long time. So this is a classical case of BPPV. Secondary might be due to the trauma or something. So what do we do in BPPV is we generally diagnose it with Dixalpec maneuver. How do we do it? I'll generally add to the end of the I'll send you the how the procedure is done at the later slides. And also, and it is generally what does the treatment of BPPV is generally, we generally write Vertin for every patient. Like Vertin is beta histone, we try it for 8 mg, 16 mg, we try for every patient. But BPPV is more of a mechanical problem, that is due to stone dislodgement. Vertin doesn't has any much benefit in the mechanical problem. So the treatment of benign paroxysmal positional vertigo after you diagnose a disc salpingo maneuver is the treatment is the correction of the the stone postural correction, that is with the Epley's maneuver. You can try Epley's maneuver, if still not possible, you can try a surgery to correct the positioning of the stones. Much of the medical management is not symptomatically managed, but they are not much benefit. Vertin and all generally doesn't help much in the case of BPPV. The patient is a 55-year-old male with a history of asthma who presents with a 2-year history of attacks of vertigo, right ear fullness, and right ear hearing loss and tinnitus. So previously was treated with steroids, which made him feel better. He subsequently had 3 more attacks of vertigo with similar symptoms in the right ear. His symptoms are aggravated by high salt diets. So he is coming 50-year-old male. Ear fullness is there, hearing loss is present, tinnitus is present, and it is increasing on salt diet, decreasing with steroids. So this you have hearing loss. When there is a hearing loss, you should only suspect 2 things. One is Meniere's disease or labyrinthitis. So he is telling that he is having ear fullness also, hearing loss is there, tinnitus is there. Episodic attacks of vertigo, to your history of vertigo, episodic attacks of vertigo is present. So this is more of episodic attacks of vertigo is generally named BPPV, and also Meniere's disease are classical cases where you find episodic attacks of vertigo, where Meniere's and BPPV has episodic, like, and there is associated with hearing loss, you generally label it as Meniere's. So Meniere's due to the excessive fluid accumulation in the endolymphatic sac. So this is aggravated by high salt diet. So this is a classical case of right-sided Meniere's disease. So they present with tinnitus, vertigo, hearing loss, and nausea, and it is generally treated with low salt diets. You can try diuretics, thiazide like diuretics, and if not, if there still symptoms are present, you can go for steroid treatment also. So and along with that, you can try your Vertin, like antihistamines and antiemetic are generally, Vertin is generally given for this patients only. So antihistamines and antiemetics can also be given. In case benzodiazepines can also be given to these patients. This is a case of Meniere's disease where you find classical episodic vertigo along with the ear fullness and hearing loss are all present. A 24-year-old male complaining of dizziness and more when he is traveling the lifts and crowded areas. On history taking, had 3 episodes of panic attacks. So like I said, all dizziness are not vertigo. Like mostly 40 to 50% cases are vertigo. Here 24-year-old male is complaining of dizziness. This is not vertigo. He's complaining of more of when he's traveling the lifts or something, he's more of lightheaded, that is about like he's about to lose control or he's about to disconnecting from the environment, he's like about to die, he's like panic mode, like hyperventilating and all. So he has history of anxiety. Like most of these patients, like who are having chronic dizziness, especially when they're telling lightheaded in the crowded areas and things, they have some history of anxiety or depression or some psychiatric history is present. When you correct that history, when you give them some behavioral therapy or desensitization therapy, or if there is acute panic attack, and try closed back ventilation, that is corrected. That can be corrected and that can be treated. That is not a significant problem. It's more of a functional problem. So all dizziness are not vertigo. Some might be lightheadedness also, which can be due to some anxiety or depression related, where they complain the significant history is more when they're telling in the closed space or lifts or something, some sort of anxiety episode, some sort of panic attacks, they will tell you. So they should be treated along with the psychotherapy and all, and also you can try when acute attack of panic attacks, you can try closed back ventilation and all. So that can be managed by this with the appropriate therapies. So 50-year-old female presented to emergency. That is, I'll also point out that is why the history taking is very important. Why vertigo present with the spinning of room. Lightheaded is more like where the high patient is hyperventilated. He has history of anxiety in the background. He's getting disconnected. He's about to die or something. He feel very uncomfortable. Like that he'll tell. So that the history taking is very important. A 58-year-old female presented to emergency with complaint of dizziness and blurring of vision. She has history of continuous vomiting episode previously. She got CT done. It was normal, so she was sent home. And next day she presented with complaint of dysphagia and dizziness and slurring of speech and ataxia. So this is the case we discussed in the start where the patient was sent home without since the patient has no stroke. Later she landed up in full-blown stroke. So always in this case, maybe HINTS examination would have helped. Maybe we would have kept her one more day or 2 more day for observation. Maybe we should have started on some anti-platelets and anti-lipid lowering therapies so that she might have not landed up in the stroke. So that can be tried. So central causes might have gone MRI also done. Maybe HINTS examination is important, especially in the emergencies and the inpatient patients, to differentiate peripheral and central causes. Maybe this is a stroke, we might have gone for thrombolysis if it is in a golden period or something. Maybe you can go for mechanical thrombectomy also. So in all the cases of central causes, you need to get a carotid artery Doppler, because if there is a significant occlusion, that can also cause decreased perfusion of the brain, that it can present as lightheadedness and dizziness. And also the patients if you can ask for the You can get a MR angiogram done. You can also ask them to like diffusion weighted MRI to rule out any stroke or something. They can all be done to look for any stroke or TA possibility in these patients. A 42-year-old male was in a recently known case of CKD and hypertension, was recently started on beta blockers and prazosin, now complaining of dizziness. So she's a known case of CKD and hypertension. She was recently started on beta blockers and prazosin. So now she's complaining of dizziness. So one of the common causes of dizziness is orthostatic hypertension, where patient will tell like he's having like he's losing consciousness and pre-sync. Suddenly like kallu tirutunattu, he'll tell like that after immediately after getting up for something. This is called postural hypertension or orthostatic hypertension. It can be due to hundreds of causes. That can be due to initially, most of them are due to the drug related, like when you start beta blockers or prazosin or ARB, like ARBs also can cause, some antipsychotic drugs can cause. They all can cause in PDE5, sildenafil can cause. So they can have initially first 2-3 days they can have a postural hypertension like symptoms, where immediately after getting you get a sudden feeling of losing of, like suddenly you feel like you're losing consciousness or something, you're blacking out or something. So this is a case of orthostatic hypertension. This is related to drug related. That can be other causes other than drug, like in the case of Parkinson's plus syndrome, like multisystem atrophy, where you have autonomic failure. Where in the case of diabetes, there can be autonomic failure also. There also you can have orthostatic hypertension like symptoms. So if it is a drug related cause, you can stop the drug. If it is not required, you can ask them to take high salt diet, and also you can advise compressive stalking. You can ask them to just stand up slowly so that it gives time for body to compensate. If still not reversible, if it is like once you stop drugs, generally it will reverse if it is drug related. If it is not drug related, if it is due to some other autonomic failure, due to diabetes or something, you can advise high salt diet. You can advise drugs like fludrocortisone, mindranone can also be tried if the autonomic failure is due to some other cause like diabetes or something. If it is drug related, you can stop the drug and see, and then mostly the symptoms will revert to normal. If the drug is still required, you can try something like compressive stalking. Maybe the symptoms will eventually wean off after 3 or 4 days. You can just assure the patient that this is the first few doses, you will have such side effects, the lateral subside. If the drug is not required, you can just stop it and just observe the patient. So that is more important. This is one more thing I want to highlight in the patient. You need to check the postural drop. So if there is any drop, like any more than 20 millimeters drop in systolic pressure, more than 10 millimeters drop in diastolic blood pressure, or more than 30 beats per minute increase in the heart rate after standing up. So that is more important to rule out any orthostatic hypertension or postural onset tachycardia syndrome. So that is also important in that cases. So that is important to check the way in the sitting in a reclined position and standing position to check for any orthostatic hypertension. So a 42-year-old female, I already mentioned this, a 53-year-old diabetic for 10 years presented with complaint of dizziness and the fear of falling, and patient was unaware of slippage of footwear. So this is a diabetic case, 10 years. He was telling he was unaware of slippage of footwear. So he was not able to feel the sensation of footwear of the ground. So he classically has peripheral neuropathy. Because of the unable to perception of the ground, because of his proprioception and mechanical receptors are not working properly, he is feeling that he was about to fall or something. This disequilibrium might be interpreted to the patient as a dizziness. He'll tell it as a dizziness only, but it is actually a disequilibrium secondary related to peripheral neuropathy. So here this is a case of peripheral neuropathy can be due to n number of causes. That can be due to diabetes, some cause of vasculitis, some nutritional deficiencies, some systemic disorder, CKD or anything that can be due to. But peripheral neuropathy can also present as a disequilibrium that can in turn interpreted as a dizziness also. So in dizziness you should ask how it is. He's about to fall or something. That is more of peripheral neuropathy problem. Even in Parkinson's case, they tell because of their slow movement and slow posturing, slow turning, they might feel they have fear of falling around. They will also tell I am feeling dizzy and all. So that is also important in this case. Dizziness is also important in those cases. A 52-year-old female, known case of hypertension and diabetes using metoprolol, was admitted to emergency with the complaint of dizziness in a way she was about to lose consciousness. On examination, her heart rate is 28 beats per minute. So she is a 52-year-old female, known case of hypertension and diabetes. She is using metoprolol 50 mg. Now she was admitted in the hospital with the complaint of pre-syncope, more of loss of consciousness, that is pre-syncope like attack. On examination, heart rate is 28 beats per minute. So this is a heart block. That can be complete heart block or a secondary heart block. That can be drug related also. So always these arrhythmias, that can be heart blocks or a supraventricular tachycardia, anything, arrhythmias, even MI event or any carotid artery disease also, they can all present as a pre-syncope like attacks also. So you should always keep that also in mind when you are looking at a case of dizziness. If they they tell you like any pre-syncope like a loss of consciousness, you should always look for the cardiac causes and carotid artery causes and any cerebral perfusion causes per se. So these are all very important. Like orthostatic hypertension also needs to be checked. So here the metoprolol might be the cause. A drug related heart block can be cause. Other cause of heart block, like any electrolyte hyperkalemia, can cause heart block. So always you need to get an ECG, you need to get a carotid artery Doppler, you need to get a 2D echo. So if required, if still you're not finding that, sometimes this might be episodic where she's having the pre-syncope like intermittently. You need to get a Holter done also. Sometimes a 24 hours Holter, sometimes 3-day Holter, sometimes 7-day Holter also can be done, so that if you are finding the symptoms significant, you need to get a 7-day Holter. Once we found for a patient 7-day, on 7-day, we didn't find anything on 24 hours. We found on 7-day Holter there is a ectopics that are present that is causing the missed beats and all, so that can explain the syncope history. So that is how. So cardiac cause also needs to be looked at, like any arrhythmia should also be looked in the case of dizziness, especially when the patient is telling pre-syncope like attacks. A 28-year-old female software engineer complaining of neck pain since 1 year and dizziness since last 2 months. So this is the new case where people, especially in the people who are working in the software industries, and especially who are working on the long hours before the laptop and computers, where they have to abnormally posture their neck and all, they are having cervical spondylitis, neck related problems. So they are complaining of dizziness. That is called cervicogenic dizziness. This is the pathology behind the cervicogenic dizziness is because of the abnormal signaling of this proprioception and mechanoreceptors present in the neck that will tell about the head position to the vestibular nuclei. This due to the abnormal signaling, it will be perceived as dizziness. So because of the disruption of the abnormal signaling of this proprioception and mechanoreceptors, and that will tell about the position of the head, due to the abnormal signaling to the vestibular nuclei, they might be perceived as dizziness. So even in the rheumatoid arthritis patient, because of the spondylitis, cervical spondylitis, they might have complaining of dizziness. That is also cervicogenic dizziness. So this is a case of cervicogenic, which is becoming very quite common in the present generation of young people who are working as a software engineers for long time before laptops and all. So we advise them the correct postural correction. We can advise them neck collar. We can refer them to the physiotherapy for exercises. If significant cervical spondylitis or any other like because of the abnormal neck angle, so that they can go for corrective surgery if significant pain or something is present also. A 32-year-old female known case of migraine present with complaint of headache and vertigo, photophobia and phonophobia. So by headache, photophobia and phonophobia and vertigo, you might have guessed by now it's a case of vestibular migraine. So they have classical history of migraine that is present. This is a case of vestibular migraine, where you give migraine treatment is you give antiemetics, we give acetaminophen, along with that triptan should be given. These 3 drugs should be given. They have classical, like they have nausea, they have headache, they have triptan. So like we give cover all of them, try, and you can give oxygen therapy also if needed. So based on that, this case of migraine, this should be managed as a migraine. I'll tell about the further management of migraine when we are discussing about headache. So these are the common causes of dizziness where we see where a BPPV, which presents as vertigo, which is due to the displacement of otoliths in the organ, which is diagnosed by Dix-Hallpike maneuver and managed by the Epley's maneuver. It's episodic vertigo without hearing loss. Whereas hyperventilation syndrome, it is more of anxiety related thing where the patient feels lightheadedness and more anxious, tachycardic and tachypneic. And meningitis is more of, it is also present as vertigo where due to the increase in endolymphatic fluid, it is also episodic vertigo with hearing loss. And migrainous vertigo we already discussed, where the patient presents photophobia, phonophobia and all. Orthostatic, they present as pre-syncope. I already mentioned how to diagnose it and all. Parkinson's also present because of the gait disturbances. They can also present as disequilibrium. Even peripheral neuropathy also can present as disequilibrium. So these are all labeled as category dizziness only, but they are categorically different. Vertigo is different, lightheadedness is different, pre-syncope is different, disequilibrium is different. So you need to categorize this first and then look at the causes. If you are looking at vertigo, you can look at BPPV, Meniere's disease, vestibular neuritis, labyrinthitis, any central cause like cerebellum, vestibular nuclear problem. If you are looking at orthostatic hypertension or like pre-syncopal problem, you look at cardiac history, any arrhythmias are present, any orthostatic hypertension, any carotid artery Doppler occlusion is present, any you look for a 2D echo, any obstruction is present, and then like severe aortic stenosis can cause pre-syncope like attacks. So those all need to look like. When you're looking at the disease, more of false like history, look at peripheral neuropathy, any Parkinson's disease, more of that problem, any ataxia like episodes are present. Ataxia can also be seen cerebral, that needs to be. Lightheadedness is more of anxiety related, and any panic attack history needs to be asked. This is how you categorize the dizziness and work up properly. So this is a patient presenting with dizziness or vertigo. Is it episodic or not? First you ask if it is episodic or not. Then if it is episodic, and then if you ask if it is triggered or not, like if it is triggered by specific position change or postural change. So then you look for Dix-Hallpike maneuver. If Dix-Hallpike maneuver is positive, you look for BPPV. If it is negative, you look for orthostatic hypertension. If it is because episodic, there is a postural change, So it is not episodic; it's spontaneous. If it is hearing loss is present, Since episodic and hearing loss is present, since it's an episodic and it is not triggered by any postural change or anything, and there is a hearing loss, you look for the Meniere's disease. And also if the migraine headache is present, that is called, if it is episodic migraine headaches are common, then you look for the vestibular migraine. Any psychiatric episodes, you look for psychiatric condition. If it is the symptoms are not episodic, they are continuously dizziness is present. So you look for any trauma or toxin history. If a trauma or toxin are present, you look for the trauma, any bar trauma or any medication can cause that dizziness and vertigo. You need to manage that, remove that drug, and if there is any specific cause, that will eventually subside, and if after removal of the drug, after removal of the causative factor, it will actually subside. No, there is no specific trigger like any trauma or toxin, it is spontaneous. Then you do hints examination, whether to differentiate peripheral or central. So peripheral, generally saccade, the correction saccade is present. It is generally unidirectional nystagmus, horizontal nystagmus, skew deviation is absent. That is peripheral. So it is a continuous, and it is a peripheral cause. It is generally vestibular neuritis. If it is, there is no hearing loss. So if it is, there is hearing loss, you label it as labyrinthitis. If there is no saccades, nystagmus is more of multidirectional, and it is skew deviation is more of central. Any stroke or transient ischemic attack should be ruled out. So this is how you work up. Okay. So this is also one more thing, patient presenting with dizziness. So the false sensation or spinning sensation is vertigo, whereas off balance or wobbly feeling is disequilibrium, or feeling of loss of consciousness or blacking out is pre-syncope, vague symptoms, feeling like disconnected is like more of lightheadedness. You should need to remember these things so that you categorize it properly. So once you label it as vertigo, if there is any migraine-like symptoms, you label it as migrainous headache. If there is hearing loss is present, yes or no. And generally hearing loss is generally present in labyrinthitis or a Meniere's disease. So if the hearing loss is present, then you ask vertigo is episodic or not. Generally Meniere's disease is episodic vertigo, whereas labyrinthitis is continuous thing. So if the patient does not have hearing loss and it is no hearing loss, episodic BPPV. If there is no episodic, it is continuously present, it is called vestibular neuritis. In disequilibrium, you look for any peripheral neuropathy, Parkinson's causes, any change in the medication history, also any gait disturbances, Romberg's test, any ataxia should be checked for. In pre-syncope, you check for any myocardial infarction, arrhythmia, and any recent change in the orthostatic, like orthostatic hypertension can also present as pre-syncope. Measure the orthostatic blood pressure. Any continuous cardiac testing, like in 2D echo, Holter monitoring, carotid artery Doppler, everything needs to be done. Lightheadedness, you can ask for history and anxiety and or any panic attack observation. You can also trigger the hyperventilation provocation test can also be done, so that if the patient feeling that symptomatology of lightheadedness again or not. This is how you work up. Medications that can commonly cause dizziness in orthostatic hypertension, like alpha blockers, beta blockers, AC inhibitors, beta blockers, and diuretics can cause any methyl dopa, nitrates can cause because of the venodilation, and central nervous system like antipsychotics, opioid drugs can cause Parkinson's, skeletal muscle relaxant can also cause because of the decrease the pumping back of blood to the cardiac circulation, and phosphodiesterase inhibitors can cause. They all can cause the postural hypertension. So these are all again mentioned: alcohol, antiarrhythmics, antiepileptics, antihistamines, these are all commonly causes that can cause dizziness. And skeletal muscle relaxants and antiepileptics, lithium can cause, anti-diabetic medication, beta blockers, aminoglycosides, anticoagulants, antithyroid drugs can cause. These all can antithyroid drugs because of the decreased skeletal muscle tone. They can cause. They all can cause this dizziness-like complaints. You need not remember everything, just remember the common alpha blockers, beta blockers, ACE/ARB inhibitors, any skeletal muscle relaxants. First they all need to be looked at. So these are the causes of vertigo. We already discussed the BPPV, and we can give, we can try antihistamine, that is vertin inhibitor, but it is not significant benefit per se, but at least whenever is more of a significant thing, that is a definitive procedure. In Meniere's we tried salt restriction, and we can try diuretics also, like thiazide diuretics, and also we can give dexamethasone and dexamethasone steroid treatment, and endolymphatic surgery can be done. And vestibular neuritis, you can try methylprednisolone therapy, and also antivirals can also be tried in the initial trial. And migrainous vertigo initially managed with NSAIDs along with antiemetics and triptans, and after that you put in the prophylaxis with flunarizine or beta blockers, whatever you suggest, whatever you prefer. So that is how you manage. BPPV is more of epilepsy maneuver, and for symptomatic only vertin is helpful, not much significant benefit. Many years low salt diuretics and steroids. And orthostatic hypertension, we can try review medication, any medication that needs to be there. We can try midodrine, fludrocortisone can be tried, and desmopressin also can be tried. High salt diet can be advised. Any disequilibrium, any peripheral neuropathy, any underlying cause needs to be corrected and proper footwear needs to be provided. In lightheadedness, we can advise breathing control exercise, rebreathing into the small paper bag in the case of panic attacks. We can give beta blockers, anti-anxiety medications like SSRIs, SNRIs can also be tried. And benzodiazepines can also be tried. So there's a common antiemetics we use like metoclopramide or prochlorperazine that can be used. Antihistamines we commonly use beta histine 8 mg or 16 mg. We can also cite promethazine or dimenhydrinate. And in significant case we can also start in the case of anxiety, we can try diazepam or lorazepam can also be tried. Thank you.